Hello, everybody, and welcome to another episode of A Stroke of Good Misfortunes. And man, I've been waiting ever since I started this podcast to have um, my guest today, and it may be pretty emotional for me because Dr. Falco. I'll introduce Dr. Chris Falco. He had a major part in my recovery and a major part in keeping my wife informed and keeping my family informed and keeping me up because there was a lot of dark days during my time with him. I got to live at his hospital basically for 5 weeks, and so Dr. Falco, man, I can't thank you enough for being on our show.
No, thank you so much for having me, Mark. It's a real pleasure, and I'm honored that you invited me to join your podcast. Thank you.
Well, I tell you, when I was living at TIRR, I'll mention TIRR right off the bat. But when I was living down there, I mean that was my home away from home, and they had assumed I was going to make it at that point. It was touch and go for a week or so, but they had me up and walking as best I could at is it Herman Memorial or Memorial Herman?
Memorial Herman,
Okay,
Memorial
so
City. You
yeah,
were initially at Mims
y-
City, right? Yeah.
yes, and so it was about 7 days after my stroke. Another good guy, Kent, had me, wanting me to get out of bed, and I was kind of upset with him for a while because I could barely feel my right side. None of it moved, and so I was like, "Hey, dude, I had a stroke, a massive stroke, less than a week ago. So I need to lay down here." And he goes, "Nope, get up. We got to go." And I'm trying to get him on the show as well. But then I got over to Tier and was put under your care, and man, what a great time. We were told, my wife, when I had the stroke, my sister-in-law is a therapist in Austin, and so she called my sister-in-law, my wife did, and said, "Where do we go?" And she said, "Julie, do not try to find some place that is just convenient to get to." She goes, "You need to be in tier, and you need to, stay after your insurance company until they approve you to go to tier." And man, what a fantastic decision that was. So anyway, I'm not going to ramble on my side. I want to know your story, Dr. Falco, and how did you get into this? And a lot of times when I ask that, these individuals I've had, they had some family member have an
Mhm.
issue, and that got them interested in the field. So what got you in the field? And yeah, let's just start with that.
Yeah. Well, I do have a past experience with a friend who had experienced a severe TBI. But believe it or not, it really didn't factor in, at least not initially, into my choice to go into this specialty or this field of practice. But yeah, I had a friend while I was an undergrad who experienced a severe traumatic brain injury in a motorcycle accident. And he had a very, very severe injury. I remember visiting him. He was in a rehabilitation facility in Austin. And I remember visiting him there and being very confused as to the condition he was in and the treatments he was receiving. And it was very overwhelming for me at the time. And at that point, I was planning to go into medicine. I was in undergrad myself, taking pre-med classes, but yeah, I had no clue what field of medicine I was going to be going into at that point. And by no means was rehab medicine or brain injury medicine on my radar at all.
Hmm.
So, but now I can look back at that time visiting him in the hospital in the rehab facility, and it makes sense now. I actually can recognize some of the things that were very confusing at the time and what was really going on. And so it's an interesting dichotomy. But anyway, so that was there. That eventually did kind of factor in, I guess, to some degree. But I went into medical school thinking that I wanted to do sports medicine. I've always been a big sports guy. I love playing sports, watching sports, and I thought no better way to combine work and play than to go into
Yeah.
sports medicine as a specialty. And so, and I also was thinking maybe orthopedic surgery, but it didn't take long for me to recognize that I did not fit the surgical world very well, and
Yeah.
I didn't feel like a good fit from a personality standpoint, I guess, more than anything. So yeah, then I focused my interest on sports medicine, and my current specialty is one of the few that is a direct avenue into sports medicine. So technically, my specialty is physical medicine and rehabilitation, or PM&R. And there is a very wide breadth of subspecialties within this field of essentially rehabilitation medicine. And sports medicine is one of those subspecialties, but you can do a wide variety of other things: brain injury and stroke rehabilitation, spinal cord injury rehabilitation, amputees. Pediatric rehab is a subspecialty all in its own. So really, any medical condition that would lead to someone losing function, any type of function, would potentially have the benefit of working with a rehabilitation doctor. And so I went into PM&R, went into the specialty thinking I wanted to do sports medicine. And of course, in our residency training, we rotate through a variety of different settings, different hospitals, different clinical rotations to get a little bit of exposure in all these different areas. And yeah, long story short, I just ultimately found myself being much more intrigued and excited to work with brain injury patients over any other subspecialty that I had exposure to. I just felt like there was something really unique about the field. It's kind of cliche, but people will say that medicine is just as much art as it is science. And I really feel like that is true in our specialty. There's so much that we do in treating patients who've had strokes and traumatic brain injuries or any other type of acquired brain injury that you can't standardize the treatment or you can't protocolize.
Yeah.
And listening to your podcast over these recent weeks, I've heard a number of your guests allude to that. Like no two brain injuries are the same, and
Right.
it's absolutely correct for sure. And so yeah, it definitely poses a challenge in that way, but it also it was what makes it interesting and exciting, and I very much enjoy it. And so yeah, now my entire practice, even though I am still a physical medicine and rehabilitation specialist, I'm now subspecialized in brain injury medicine. And so that's my entire practice is here at TIRR Memorial Hermann, working on the inpatient side of things and caring for patients with strokes and brain injuries.
Are you primarily focused on strokes, or it just doesn't matter what kind of brain injury it was?
Yeah, it doesn't matter. I get a little bit of everything. I'd say about a third of my patients, maybe a little more, have had strokes, and another third or so are here after a traumatic brain injury. And then the final third are a variety of other types of acquired brain injury. It could be an anoxic brain injury, for those individuals who have had a cardiac arrest and then lose blood flow and oxygen to the brain. Oftentimes they'll experience a brain injury. We get a lot of those anoxic brain injury cases. And brain tumors, any type of disease process that can affect brain function would potentially fall
Yeah.
under my purview and could be here at TIRR.
Yeah. Well, in case anybody hasn't listened before, mine was a hemorrhagic stroke, and so a brain bleed, and and you can correct me if I'm wrong, but an ischemic stroke sometimes you can reverse with medication.
Mhm.
Is that right? A
Correct.
hemorrhagic is just bleeding, so you can't take a medicine to get it to stop. You just have to hope and pray that it stops. And if it doesn't, what you guys go into a surgery of removing the scalp. Is that correct?
Mhm. Yeah, there's a few different options. Really, the main surgical indication would be if the bleeding and the swelling in the brain has reached a point in which it's causing too much pressure within the brain, and that needs to be alleviated or decompressed. And they can go in. The neurosurgeons can decompress the brain by either removing a very small little window of the scalp and the skull and just draining the blood, and that's sufficient. But sometimes they have to go in and actually remove a very large portion of the skull and then keep it off for a prolonged period of time, usually for a few months at least. And those are the cases where the pressure and the bleed is very severe. And I know, listening to your podcast and recalling your case when you were here, you ultimately did not require any surgical intervention.
Right.
Fortunately, but still, I know yours was still a rather large bleed.
Yeah, and talk to us a little bit about the the importance of how fast you get to the hospital and get help and get this thing under control. Because we had a guy right next to me. His name is not important. It's not needed, but he had a stroke, the same type stroke. Um, I think 3 to 4 months ahead of me, and so he wasn't. But he didn't get found until his daughter had gotten home, about
Mm,
4 to 5 hours later, and so he had just slumped over at his desk for 4 to 5 hours. I noticed mine right as I reached to get my drink. I noticed I couldn't move my arm, so I couldn't
mhm,
reach my drink. So immediately I was on the floor trying to get to my phone. I mean, I'm sure you've seen the story if you watch the podcast. And so
yeah.
I had the ambulance at my house within. I was in the ambulance within 30 minutes and headed to Memorial. And so yeah, talk to us about how important it is to get immediate help if you start
Mhm,
having
mhm.
some not side effects. What am I thinking? Some um,
Symptoms of
symptoms of
yeah.
yeah.
Yeah, it's critically important. The adage, time is tissue. Every passing second might further jeopardize the ability of the brain to sustain that injury or to eventually recover. And each passing minute, it just further increases the chance that it's going to be more severe of an injury. And like you said, for an ischemic stroke, if you can get to the hospital promptly, within a few hours, there's a number of interventions that can be done to try to uh, essentially remove the blockage and reestablish blood flow to the brain. In your case, or in
So
the case
let
of
me let me ask you real quick. Can you go over what an ischemic is
yeah, so an
for
ischemic
anybody
stroke,
listening?
ischemic stroke occurs when there is a blockage to an artery in the brain. The arteries are what provides blood flow throughout the brain. There's a number of large arteries throughout the brain, but a blockage in any of them will lead to significant damage to the parts of the brain that they normally supply blood to. And it does not take a terribly long amount of time for the damage to set in. As soon as the clot occurs, the damage can begin very, very quickly within a matter of minutes, and certainly within hours. A lot of uh, severe, potentially irreversible damage can be done. And so, yes, it does underscore, as you said, the importance of seeking treatment very, very quickly. Um, and it does also apply for hemorrhagic stroke. As you mentioned, there is not the reversible treatment necessarily, but still getting to an emergency department, especially a high level stroke center where they have the ability to do urgent neurosurgical interventions and other stroke related interventions very quickly, is really important. If for no other reason, for a hemorrhagic stroke, to make sure that the bleeding is not getting worse, or to take you to the operating room quickly to decompress the brain. Because in addition to the area of the area of the brain where the bleed occurs, there's going to be local injury to that brain, to that area of brain tissue. And it's a combination of, like toxins from the damaged blood vessel affecting the brain tissue, but also direct pressure on that area of the brain by the bleed, compressing brain structures. But furthermore, if the swelling and the bleeding reaches a certain level to where you're getting increased pressure throughout the brain, because the skull is a very tight fit. The brain doesn't have a lot of space to swell before it starts getting compressed kind of globally within the skull. And if that goes on uncontrolled without a surgical decompression, a surgery to alleviate the pressure, then that's what ultimately proves to be fatal in many cases. Or that leads to, even if it's not fatal, leads to much, much severe injuries and damage to other areas of the brain, even not even directly correlated with the original bleed, but other brain structures. So
Okay.
yes, it's critically important to seek attention at the first signs or symptoms of a stroke.
Mm. Well, when I went to the ER, or when I got picked up by the ambulance, my wife had been on the phone with a neighbor, because a neighbor saw the ambulance in the driveway, and she said, go in and see what's going on. And then they told her that looks like, he's had a stroke. And the lady in the ambulance, and I wish I could track her down, but she said, we're taking him to Memorial Hermann because they're the best stroke hospital in the city. And mind you, I've got hospitals all around my house. They could have
Yeah.
taken me to any one of them, and they said, nope, we're going to Memorial Hermann, because uh, that's where he needs to be with this type of a stroke. And well, I don't know if they said this type of stroke, because you don't know what kind of stroke it is until you get to the hospital. And
Right.
but they just said they are the best by far. And so we probably passed 4 hospitals getting to your hospital, and thank God we got to Memorial Hermann. And they did the scan right then. And I didn't know this until about a year later, but my daughter, who was the only one at the hospital with me, they told her, we don't know if he's going to make it. It's bleeding pretty bad. And I don't know how it stopped, but it stopped, and I'm very thankful for that. But when you say that can be the fatal part of it, when it just keeps bleeding and all that, what I've heard a rumor, and maybe it's just from my looking online too much, but is it true that they don't want you to fall asleep, um, right after a stroke? Because a lot of times you fall asleep and you never wake up. Is that true, or is that a myth I've heard?
Now, there is truth to that, but mainly it's so that the patient's neurologic status can be monitored. You want to know if things are deteriorating. Are they experiencing worsening symptoms? That would be an indicator that the bleed is getting worse. Because they can only scan you so frequently, and so yeah, usually they would rely on serial neurologic exams. Is the patient's weakness getting progressively worse minute by minute, hour by hour? Is their speech getting worse? Any other neurologic sign that the brain is getting worse, and something might need to be done. And yeah, really the best way to track that in real time is with neurologic examination. They're at the bedside. And so yeah, it's important that the patient's awake and interactive as much as possible to track that accurately.
Yeah. Well, I mentioned maybe before we even started, before I hit the record button, all the stuff that you guys did in regards to keeping my wife up to date and all of that. And Dr. Falco would, my wife had to go back to work eventually. I was not able to work for, I don't know, about 6 months, which is a miracle. If you see the state I was in September and early October, to be able to go back to work and walk up 22 stairs within a few months was pretty amazing. I didn't stay here very long because this same Dr. Falco really got upset with me that I was working at the working in the rehab hospital, and he didn't like it. So I apologize to Dr. Falco right now. But what you didn't know, or maybe you did know, but my helper was in the Texas National Guard. Well, he got pulled down to the border
Hmm.
because the Texas National Guard got pulled down there to stop all the crossings, and so I didn't have anybody at my office to do what I need to do. He did some of the stuff at night, but yeah, there were a few loans that I need to get done, and I know you weren't happy about it.
I remember that. I do recall discouraging that. And really, I was, in retrospect, I recognize now that you were doing quite a bit better cognitively than I probably recognized at the time. But I remember that was, still relatively early in your stay. We were still trying to assess what your true level of cognition was, because as you said, your speech was still rather limited at that
Yep.
time, and so it's difficult when we can't just ask you questions and you easily respond verbally. It's difficult to do a real in-depth cognitive assessment, which is usually what's necessary to prove that a patient is ready to return to work or resume working. And I was trying to look out for your best interest. The last thing I wanted was for you to make some type of mistake on a loan and it end up causing a bigger problem for you. But yeah, I do remember that, and I think if I recall, we ended up compromising,
We
and it
did.
ended
We
up working
did.
out okay.
Yeah, I would do rehab from, I think they'd pick me up at 8 o'clock, 8 o'clock, and then 9 o'clock, and then I think I had a break, and then Jill would come in, and you always came by at 2 o'clock normally, or around that time, and that's what I was getting at a while ago, is he always kept my wife updated on what was going on, and this guy and his team would record my status into her phone, and it would either be a message to her because she'd say, "Hey, it's going to go to voicemail, just leave a message." And he and his team would leave long messages to make sure she was up to date on how Mark was doing, what we're doing the rest of the day, and so she that was such a relief to be able to have her go in and listen to the status of where I was, if she couldn't get on the phone, while you were in there with us, because there were sometimes we just called her and you would talk to both of us at that time.
Yeah.
So I know that meant the world to her. And by the way, she told me to tell you hello and that she loves you and your team. And I know that kind of sounds weird, but I love these guys. It's that getting me back to as near normal as I can be, or the new normal that is face me. That whatever it is, these guys, they did it. They
Mhm.
did it. So tell me about like when you would come in with your fellows or fellas. What do you call? Are they called fellas or fellows?
Fellows, residents, and
Fellows.
fellows. Yeah.
Okay. So you guys would come in and discuss what you guys had talked about with the therapist, correct? Did
Hmm.
y'all meet like once a day to say, all right, Mark is at this level or that level? Well, how does that work?
So we do have a very tight collaboration with all the therapists. There is a lot of communication taking place day to day between the resident, or yeah, between the physicians and the different therapists. We have a formal meeting once a week. We would have our weekly interdisciplinary meeting where all the different members of your team come together. Really, the intention of the meeting is to review the patient's progress over the past week, try to identify where we're at as far as what goals we'd set for the patient. Are we progressing towards those goals? And are we doing so in a reasonable time frame? Knowing that insurance companies and Medicare unfortunately restrict how long patients are with us. And so we've got to be very mindful of how quickly we're progressing through the recovery process with patients and make sure that everything is coming together. And, some patients make leaps and bounds of progress very rapidly, and that makes our job very easy. And a patient like you made our job very easy with how well you did. But then other times, oftentimes patients don't improve so quickly. And so there's a lot of discussion and planning, being very thoughtful about what do we need to do to ease the patient's ultimately difficult transition from the hospital back to home. And so that's really the main gist of those weekly meetings. And yeah, from there, I usually would take that information and make it a point to update the patients and their families on what we had discussed. But yeah, every day there's a lot of cross communication going, me communicating to the therapist and then in return. And that's one of the unique things about rehabilitation medicine. I mean, all specialties, all fields of medicine, of course, have some level of interdisciplinary care. But in most places, it's a lot more siloed. The physicians are going to do their thing, and then any other ancillary staff is going to do their thing. But in rehab medicine, it truly is a team effort. I mean, for everything to come together and work the way it really should, everybody's got to be on the same page. There's got to be a lot of really intense communication taking place. And I take great pride in our team, and I think TIRR in general does a really, really great job of that. And so a lot of good dialogue happening at all times. And part of my job is to make sure that patients and their families are aware of that. I try to be very transparent as far as what we're seeing, how we're feeling about patients' recovery, and how they're progressing with therapy. And of course, just update them on any medical things, because that's the other part of my job, in addition to answering questions and updating patients and families, is managing medical issues that are coming up that might be interfering with the rehab process. So and that's what we would discuss on a day-to-day basis, and those would be the things I'd include in the messages to Julie.
Yeah. So you would only meet with formally with the team once a week, but then I I almost know, and maybe you can correct me, but you came by almost every day, and
Yeah, I would see. I see all my patients every day, for the most part, and a lot of times I do make it a point to see patients while they're in therapy, because then I can talk with the patient. The therapist is right there. A lot of good discussion can take place, and yeah, it really is just another example of the interdisciplinary management that we provide. But
yeah.
yeah.
Well, so what is your opinion on, um, being a stroke victim? You go through, there's certain rehab that you have to go through. Do you think that it's a lot different? The approach is a lot different with orthopedic rehab versus brain injury rehab?
It can be. There are some specifics, some very unique aspects of the rehab process for a patient that has experienced a significant neurologic injury, so stroke or traumatic brain injury. And so, yes, if you were to go to, and this is often what I'll tell patients too, because oftentimes as we're preparing to transition out of TIRR back to home or back to the community, one of the important steps is identifying where they're going to continue to get more rehab as an outpatient. And I strongly encourage patients to choose an outpatient facility that does specialize in neuro rehab, because I know beyond a shadow of a doubt, if they do, like I know if they're going to do outpatient at a TIRR facility, that the therapists working with them are going to be neuro trained. They will have tons of experience working with stroke patients, and that is helpful. That being said, an ortho therapist, even if they haven't worked with a ton of stroke patients over the years, they can also do a fantastic job. honestly, I think just as much as that experience and understanding neuro rehab, just as important as that is just the connection with the therapist. I think if you
Mhm.
if the therapist can establish a great rapport with the patient, get them to buy in as to what we're trying to work on, and as long as they have some reasonable approach to what they're trying to accomplish with therapy, that would be a very successful rehab plan, I'm sure. So, yeah, it's always preferable, all things being equal, but there are tons of orthotherapists out there that could do a fine job, no doubt.
Yeah, yeah, I have had some great ones. I went to you referred us out to Tier Challenge
Hmm.
out in the Woodlands, and man, those guys were incredible. The Dr. Biney, although she made me extremely upset at the beginning because she was making me go through these test of these patterns and all this math and spelling, and she'd read off, you know, six or seven numbers to me, and she'd say, okay, now repeat them back to me backwards. And
Hmm.
oh man, she was firing me up, but she turned out to be one of my dearest friends because she would explain to me why she's doing it. She go, Mark,
Yeah.
we got to see where you're at so we know, you know, I just see where we're at so we know where we need to go.
Hmm.
And understand she's moved to Alabama now, but man, if I could find her, I would love to have her on the show as well. But Tier Challenge was an incredible time for me with Eva and Megan, and I mean, I still know I'm trying. They're all just. We had a year party after I survived, and invited all of them out there. You were invited. You couldn't make it that day, but I think maybe we ought to have a 5 year reunion if I'm still around. I hope to God I am, but they were all
Yeah.
just so super nice, and I would love to have Delma on as well. But back to the question, the only thing I saw as the main difference is, it, the neuro specialist, it's you and her or you and him, and
Hmm.
then on the ortho, it's you and three others or two
Yeah.
others while they're working on all that they have to work on because they said we could stay in business by just doing one, and I understand that, but they had great helpers that you know took over when the therapist went to another person. So
Sure.
what
Yeah.
what kind of big advances are you seeing in brain injuries or brain stroke rehab? I was amazed by the tools that were available to help a stroke victim. You know,
Hmm.
the mirror therapy and all. I did stuff I
Hmm.
didn't even think about. Have
Yeah.
has there been any major breakthroughs in the last 5 years or so that you can point to? Like, wow, that was life changing.
There's a lot in the works. There's a lot being researched as far as big breakthroughs that are now kind of game changers and are standard of care. Not really, unfortunately. But there is a lot of really cool stuff happening from certain robotic devices. You know, we can
Mhm.
now get patients up in these very elaborate exoskeleton robotic devices that'll actually help the patient walk, that, you know, in a case that they otherwise would not be able to ambulate. There's a lot of research looking at different types of brain stimulation devices, either, you know, direct current, electrical stimulation to the brain, or magnetic stimulation to the brain, and or TMS it's called, and looking at whether or not these stimulating devices can improve stroke recovery in a number of ways. You know, looking at specific things like speech recovery or motor recovery, you know, strength recovery, and other aspects of stroke recovery. And there's some studies that have happened in the last decade or so that look somewhat promising, but then it seems like every time we grasp something that looks promising and they take it to the next step and do a bigger study, it's a little less convincing. So yeah, and there's still so much out there, and I'm sure at some point in the not too distant future there is going to be a big breakthrough with technology advancing as quickly as it is, and AI really starting to take over.
Right.
I think that's kind of scary on one hand, but on the other, I think there's a
Yeah.
lot of promising benefits that could come to the medical world, and specifically to stroke survivors. So, yeah, it's exciting and kind of scary and overwhelming all at the same time, but definitely
Yeah.
reasons to be optimistic. It's going to help patients moving forward.
Well, backing up to how do you best prevent even a stroke? I mean, you hear the blood pressure and all that, but kind of walks through what are some ways that someone could just say, you know what, my family has a history of this, so I need to do this to minimize my probability, I guess, of having a stroke. What would you recommend?
Yeah, if you know you have a family history, a strong family history, then most importantly, just make sure you're connected to a doctor, even just a primary care doctor who can do some initial kind of screening tests and making sure that your risk factors are being best controlled or best managed. And that's, for all different types of strokes, regardless of the type of stroke, minimizing risk factors is the key. And the biggest risk factors are blood pressure, cholesterol, diabetes, if you're a diabetic, making sure your sugar's controlled. If you're a smoker, stop smoking. That's the single most um, easily modifiable risk factor.
Mm.
Um, and then, of course, other things that are out of our control, like age. Just as we get older, it's more likely that we're going to experience a stroke. Our blood vessels harden over time, and even for those who do a pretty good job of managing their risk factors and those medical comorbidities, inevitably plaque is going to build up in our blood vessels, and they'll slowly get more narrow, narrow and more narrow over time. But yeah, the best you can, manage those risk factors, the less likely you'll be to have to experience a stroke.
Yeah. Can you tell us a few symptoms that someone may have that they need to call the EMS and say, "Hey, I'm having these symptoms. I think I may be having a stroke." What are some major symptoms that you can share with us?
Yeah, so the most obvious are going to be weakness on one side of the body, and that could be difficulty moving an arm or a leg, or facial droop, where the lower part of your face is sagging and not able to move. Um, Difficulty speaking is another one, although that would typically, I mean, it could be slurred speech or just difficulty getting the correct words out, which, as I think I've heard you say in your previous podcast, you probably were having a hard time getting the correct words out, but you didn't even realize it at the time.
Yes.
So yeah, that's why that one is a little more challenging sometimes. But yeah, that the weakness, sudden onset weakness, especially affecting just one side of the body, and the difficulty talking, those are the big ones. If you're experiencing that, I can't tell you how many times I've cared for patients who experienced those symptoms and they thought, oh, well, maybe I just am coming down with the flu, or I got some other medical thing going on, and I'm just going to go sleep it off. And then they wake up a few hours later and things are even worse. And like we talked about just a few moments ago, at that
Yeah.
point, too much time has passed for a significant intervention to take place that could have helped. So, yeah, it is important if you're experiencing something like that to seek medical attention very quickly.
Yeah. Well, there's got to be a lot of ups and downs in your industry as a
Mm.
doctor, and you see so many success stories, but I'm sure that there are a lot of down days you're like, man, is this worth it? I mean, what do you enjoy the most about this industry, and what's the
Mm.
biggest challenge that you have? I guess my question is, are you able to even turn it off at the end of the day and you go home and enjoy your family? Because it's got to be such a stressful role.
I I can tell you I try to separate work from my personal life. Um, but my wife will be the first to tell you that I don't. I
Really?
definitely bring it home. Um, yeah, I've had many nights lying in bed wondering what am I doing wrong for this particular case. This patient's not improving the way I would expect. What am I missing? Um, so yeah, it is hard. It's hard to turn it off. Um, but you know, they they kind of they prepare us for that in medical school. You know, they
Really?
unintentionally, I think, desensitize us to a lot of things, which I'm somewhat ashamed to admit. But it's just it's a coping mechanism. You know, we sort of have to compartmentalize. So, but still, it is hard. It is hard, especially in our field where patients come to TIRR just like you, and you stay for weeks and weeks, and we get attached to them, and we get attached to their families. We establish these relationships, and when things aren't going well, and you start to feel like not only am I missing something, but I'm letting the patient down. I'm letting their family down,
Mhm.
and I need to find a way to fix it. So yeah, it's hard to separate them, but I try.
Yeah, and part of the frustration need probably is you do leave after or we do leave after a while, and you probably wonder what in the heck happened to them. Did they make it? Did they go to the challenge program like we asked them to, or did they throw in the towel and just put me in the rest home? I give up. I mean,
Yeah,
that's got to be hard right there, just not knowing whatever happened to your patient.
it really is. Because yeah, I don't know. I'm in right or wrong, for better or worse. The way our practice is set up, I only work in the hospital for patients that are admitted to the hospital. We always have them come back and see our doctors in the clinic for follow up appointments, or if they live local to Houston at least. But that's a different doctor that then takes over their care and continues to see them in the clinic over the following years. But I personally don't really get a chance to see them again. And I often wonder whatever happened to this patient. And I'll tell you, there's many times where I'm tempted to pick up the phone and call them or call their family just to say, hey, how are things going? But I'm always hesitant because, for all I know, they hated me, and I'm the last person they want to
No,
talk to. They
that
blame
that could
me for
not
not
that could
doing
not be true. That could not be true at all. So how many patients do you see at a time? I mean, are you overseeing how many, you know, I don't know, if you're going in every week and I mean every day and seeing your patients, are you assigned to a floor or a wing in the floor, or how does that work?
So I typically carry anywhere from 12 to 16 patients at a time. And there is a specific unit in the hospital where it's considered my primary unit. So they try, if they know a patient is coming to TIRR and they're going to be assigned to me and to my team, they preferentially will admit them to that specific unit if there happens to be an open bed. But TIRR tends to
Mhm.
stay pretty full most of the time. So very frequently they're admitting to other parts of the hospital. So I'd say of all of my patients, about half are on my primary unit, and then the other half are scattered around all the other different units in the hospital. But yeah, anywhere from 12 to 16 is pretty typical.
Okay. Yeah, I think when I was admitted there, all the beds were full on a certain floor, so they had me go to the kids floor, and
Hmm.
I don't remember what floor that was. Maybe six at the time.
Yep. Yeah, it was
But
6.
I got that right. So Dr. Biney would be happy about that. But yeah, so they had me on floor number six, but there weren't that many adults on that on that floor, and I don't know if all of six is allocated towards this just kids or just that wing or whatever. But yeah, I was on a different floor than I would have been. but I'm glad I was on that different floor, and I'm glad we got you as our team leader.
Yeah, yeah. No, I remember. I distinctly remember what room you were in, and yeah, that the sixth floor does a great job. Even though
Yeah.
they're not my primary unit, I have great confidence of all the nurses up there, and the nurse manager Deanna is amazing. And yeah, you had a good nursing staff working with you, in addition to a great team of therapists for sure.
We sure did. I think Julie made friends with every one of them on social media, and we still keep in touch with them. I need to go up there and just roam the halls if that's even allowed to say hi to all the people that
Absolutely.
helped
I
us
know
out.
we would all love that for sure.
Well, I remember the day that I went back up there to get uh, I think it was a Botox shot in my foot and my legs. I didn't even know Botox was for that until I went up there and like, no, I think my lips look fine. I don't need Botox, but yeah, I had that, and I happened to run into you in the hallway,
Yeah.
and man, what a honor it was to do that, and it was so good to see you for sure.
Yeah, I remember that. Yeah, it was great to see you, and I knew you were doing well. I had heard, again, the therapist and I, we stay in close communication, and
Yeah,
they share what they're hearing and what they're seeing. And I had been hearing rumors that you were doing really well, but it was great to see you and to see it myself. I was really impressed with your recovery for sure.
well, it wouldn't have been near the recovery without you guys. Poor Jill, I would get upset with her. I guess when you're a stroke victim, you just get upset a lot because you're not used to having to do all these things that they have you doing. Like she'd have me biting my tongue and swallowing or trying to swallow at the same time to try to get the muscles to re-engage. And so a lot of fun stuff that was going on that you look back on and you're like, now I see why we did that. And it and it
Yeah,
was
I distinctly recall you were pretty frustrated for a lot of your time, at least initially. Understandably, I remember your speech and ability to communicate was more limited than you would have preferred, of course. And yeah,
yeah.
you had the misfortune, unlike a lot of our other patients, of being so highly aware of your deficits. That's one of the challenges, with a stroke, is that oftentimes patients will have these major deficits, but they are also not fully aware that they're even having them. Their insight into what's going on is limited, and so no matter how much we try to educate them and bring it to their attention, they don't recognize that they're struggling as much as they are. But in some cases, like you were very aware, hyper aware, and it was very frustrating. I remember, but I do
Yeah.
remember by the end of your stay, you had made such great progress, and you just did amazing. So, but
Yeah,
yeah,
I I remember a day that you guys heard me talking to somebody else, and you were very surprised at like the improvement that I'd made from the previous day to that day. They're like, y'all were like very shocked that you could. I don't know. Maybe I was enunciating better than I had in the past. But you're right. I was not aware of it at the beginning because when I was going down to the hospital in the ambulance, I thought I was carrying on a pretty good conversation with this guy in the back with me about college football, and
mm,
then my daughter sent me a recording that I had called her to take Scout to the vet because we had a vet appointment for Scout. And for some reason, I remembered that. I couldn't remember much, but I remembered that. And so I called and left her a message. And it was the biggest jumble. I mean, I
mm,
couldn't understand what I was saying. So I don't know how she even picked up on what I was saying, but she got the word and took Scout. But yeah, I was very unaware of how I sounded until I guess Julie kind of clued me in that Mark, we really can't understand what you're saying, and I couldn't write anything down, but we could text one finger at a time. But
right, yeah.
So what's the most frustrating part of your role? And I'll go ahead and let you go after this because it's been 49 minutes, and I know you have to get home to your family. And so, what's the most frustrating part of your job?
Oh gosh, without a doubt, having to deal with insurance companies. It's very frustrating to know what a patient needs and to know that if I can just have the ability to keep the patient here a little bit longer to get this intense rehab that I know is benefiting, that they're going to do better, that it's going to be meaningful and helpful. And then for an insurance company to step in and say, no, we don't agree. We don't think that's necessary. And we think the patient should discharge. And then when I counter that with, well, where would you like the patient to discharge to? They still need a lot of assistance. When they say, oh, well, they can go to a nursing home, it angers me. I get
Wow.
physically angry. Um, and yeah, once they've made that determination, it's very difficult to change their mind. And so, yeah, that's by far the most frustrating part of it is for people who know very little about rehab medicine to have such control over what's happening for patients.
Hmm. I don't know how many interviews I've done so far, but I think every single one of you have said the same thing. And
Yeah.
part of the reason I started this next step neurological support network is my wife went round and round and round with insurance, and so some people just don't even know where to start. And that was going to be part of our nonprofit. Is Julie will help with, here's what you need to do, this the steps that you need to take to get to the right person that's going to get you the right answer. Because let's admit, a lot of times you just have that first phone call and they say nope, and you're like, okay, and then
Hmm.
you're off to the rest home or whatever. And uh and so patient patients need an advocate for
Absolutely.
them to know what's the process of getting insurance to at least relook at their decision.
Hmm. Hmm. Yeah,
So
they absolutely do. It's unfortunate that patients are forced to have to advocate for themselves. They work hard at their day job and they pay these premiums month after month after month. And when they finally are in a situation where the insurance is obligated to hold up their end of the bargain and give them what they need, for them to try to save a buck by not allowing them to go to the best place possible, it's just maddening. So,
yeah,
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 it's great what you and I had chatted about prior to starting this recording, and the stuff that you've got in the works, which I'm sure you are going to be sharing more on. But yeah, there's definitely a strong need for advocates like you. Absolutely.
yeah. Well, I tell you what, I can't thank you enough for being on my show, but more importantly, for running my team while I was at TIRR. And man, I just can't imagine. I don't even think where I would be without you and your team and the people that you had working with me and for me. And man, my family will forever, forever be grateful for all that you did for me.
Well, you're very welcome, and I appreciate the kind words. Definitely. It's very easy working with patients like you. Like I said, we quickly establish relationships with our patients, especially those who have amazing patients and families like you and Julie. I remember just being so relieved to have such a welcoming and just courteous and appreciative family along the whole way while you were with us. So yeah, and it's what brings me joy every day. It's why, even though, like you said, I see some terrible stuff. You know, if you've been a patient at TIRR, something really, really terrible has likely happened to you, and for me to see that every day, and it can be a lot. But then when I see patients do amazing, like you,
Yeah.
it really makes it all worth it. So thank you.
What? Well, I tell you, you better be glad that COVID was going crazy back then, because you would have had a room of 20 or 25 family members, because we're all very close and they all wanted to be there so bad. and we
Yeah,
could only have one visitor per day, not one at a time, one per day. And
that
so
was
that really,
terrible.
yeah, very, very awful. But
Yeah.
anyway, thank you so much. And it's been a pleasure having you on here.
No, it's been my honor. Thank you, Mark.
You bet. Well, guys, I do want to mention the Next Step Neurological Support Network. You can go to nextstepnsn.com to see our website and find us on Facebook and um, all these different social media sites. We just started work on our YouTube channel, and we want to be a support for anybody that may be going through this. And we're going to turn this very negative situation in our lives to be as positive as it can be. So we want to help with those parking permits and the food that people have to buy and the co-pays and things like that. And I can't build a hospital like other people that are worth billions. I'm certainly not there, but we can help with co-pays and therapy and all that kind of stuff. So, and we can only do that if we have support. So you go in and just help us help someone take their next step. And I started my mortgage company, Next Step Home Loans, years ago, and I didn't know the next step was going to be so significant in my life, because it is. And we, through this nonprofit, are helping people take their next step, simply by helping any way we can, finding a wheelchair, and it just all that money adds up to a lot of money in a very short period of time that we've learned. So anyway, go check out our website, nextstepnsn.com. But thank you again, Dr. Falco. It's been a pleasure.
Thank you, Mark. Likewise.
All right, guys. We will see you next time with our next podcast. I'm not sure who we're going to have yet, but we'll have a great life changer, just like Dr. Falco. And but thank you for joining us on this week's podcast, and we'll see you soon. Take care. Bye bye.